Imagine this. You're running a busy shift, and the phone just seems to be melting in your hand. You've got two issues, both screaming for your attention, both high-stakes dilemmas about sharing patient information. Patient A, who is totally with it, fully competent, asks you to ring their close relative. Just, give them the basics today. Seems simple enough. But before you can even dial, patient B's partner calls. Now, patient B is confused after a bad bout of delirium, and the partner is insisting, really demanding full details on every single medication change, every blood result, the whole discharge plan. You know they're a crucial carer, but how do you even begin to navigate that moment?
It's such a classic tightrope walk, isn't it? That tension between wanting to support the family, who are essential, and upholding your absolute legal and ethical duty to the patient.
Exactly. And that is what we're going to unpack today. This is our deep dive into mastering that vital but consistently tricky area of working with relatives and carers. It isn't just about being polite. It's where legal standards, professional ethics, and just daily practicalities all collide. We're using some structured sources to give you that high-yield framework for making these calls.
Right. And the central exam truth for this, which honestly translates directly to your professional defensibility in the real world, is this phrase. Center the patient's wishes. Share the minimum necessary securely. Involve carers appropriately. And document.
And if you miss any one of those steps,
especially the documentation, you are leaving yourself professionally vulnerable. This whole area is guided by the GMC, the Mental Capacity Act, and NICE guidelines. Getting it wrong is one of the most common pitfalls we see.
That just immediately highlights the tension, doesn't it? Relatives and unpaid carers are so essential. They're partners in safe care.
Absolutely, especially at discharge.
But the patient's autonomy has to come first, always. So the sources seem to suggest that being proactive is the key here, not reactive. What's the very first practical step we should take?
The first step, and this is core GMC guidance, is to agree in advance what can be shared, with whom, and when.
So not when the phone is ringing and the pressure's on?
No, that's too late. It can't be an afterthought. It needs to be a documented conversation you have right at the beginning of an admission.
So we need to build in a kind of check preferences early step, right into our initial assessment.
Precisely. You have to ask specifically, who would you like us to involve in your care? What are their names? And what exactly can we share with them?
And you document all of it.
You must document those names and the exact boundaries. If the patient explicitly says, don't share anything with my son Bob, that instruction must be honored. It doesn't matter how helpful Bob thinks he is.
Okay, let's talk about the minimum necessary share then. It's a phrase we hear a lot. Clinicians often feel this pressure to be helpful, and they can just, information dump. So if I've got consent from patient A to update their relative, what does minimum necessary practically exclude?
That is a crucial distinction. Minimum necessary is all about what is required for the safe and appropriate delivery of care.
Okay.
So if a relative is collecting the patient and needs to know the new insulin dose, that's necessary. What's almost never necessary are, say, historical details that aren't currently relevant.
Like a diagnosis from 10 years ago?
Exactly. A decade-old diagnosis, old psychiatric history, or, and this is critical, financial or employment details. You are sharing clinical facts, not the patient's entire life story.
And we absolutely cannot forget the security checks, especially now, with personal devices everywhere. What are the non-negotiables before you disclose any information over the phone?
You have to verify identity and consent. When a call comes in, you need a verifiable method confirming date of birth, address, maybe an agreed-upon code word the patient gave you. You have to be absolutely certain you are talking to the right person.
And the channel itself matters.
Oh, hugely. Professional communication has to happen via approved channels. That means no personal emails, no unsecured messaging apps like WhatsApp, and definitely no sharing of full clinical notes to a relative's personal device. That is just excessive and insecure.
I think having the right language, ready to go makes all the difference when you're under pressure. The sources give these brilliant GMC-aligned phrases that just reset the entire interaction. So for the competent patient, you can just say, with your permission, I can update your relation on the key points today. What would you like me to share and whatnot? It's direct. It's respectful.
It is. And if you're speaking to that verified relative who's helping with care, you need a line that manages expectations right away. Something like, before we discuss details, I'll just confirm who I'm speaking to in your relationship. Then I'll share only the essentials needed for care.
I like that. It establishes security, it limits the scope to essentials, and it keeps things professional.
It does.
Okay, here's where it gets really interesting. And I suspect where most of the legal trouble starts, If the patient has capacity, we follow their wishes. Easy. But let's go back to patient B, the patient who was confused after delirium. Capacity's fluctuating, maybe lost entirely.
This is the critical moment. If capacity is fluctuating or lost, you immediately have to switch to the legal pathway. The Mental Capacity Act, the MCA.
And the requirement is?
Absolute. If capacity is in doubt, for any reason, confusion, delirium, intoxication, you must assess capacity right then and there for that specific decision. You can't just assume.
I know time is often the biggest pressure here. Clinicians know they need to assess capacity, but what's the single biggest mistake they make when they rush it?
The biggest mistake is failing to see the difference between general confusion and a lack of capacity for the specific decision.
Right.
A patient might be confused about the day of the week, but still totally understand that sharing their diagnosis with their partner is a good idea. The assessment has to be decision-specific.
And if that assessment confirms they lack capacity for this decision?
Then you must follow the mandatory MCA best interest process. No shortcuts.
Let's break that down because I think best interests process can feel a bit overwhelming. What does consulting those close to the patient actually mean in practice?
It means you actively seek out their next of kin, their named carers, anyone close to them. But, and this is key, it's not to follow their wishes.
Oh, okay.
It's to gather insight into the patient's own past wishes, their values, their beliefs, their feelings. You use that consultation, plus the medical facts, to weigh the benefits of sharing against the risks.
And the decision you make has to be the least restrictive option possible.
Always. And the key professional safeguard is the documentation.
Of course.
You have to record everything. Who you consulted, what they said about the patient's wishes, what you decided to disclose, and why you felt this was in the patient's best interest. That note is your legal defense.
So let's go back to our patient B scenario. Fluctuating capacity. When they were lucid, they said yes to involving their partner, but specifically said, please don't share financial details. Right. Now they lack capacity. The partner wants everything.
Okay, so the correct approach is layered. First, you assess capacity today. If it's lacking, you start that best interest discussion with the partner. But crucially, even in that process, you must honor the patient's prior preference about the financial details.
So you don't just override their past wishes because they're confused now?
No, the duty of confidentiality persists. That refusal is a vital part of the best interest consideration. You share only the minimum necessary clinical information for safe care meds, discharge instructions. You deliberately exclude the financial stuff because the patient drew that line.
Okay, let's shift gears slightly, away from the legal side and more towards the duty of support. We focus so much on the clinical facts, but what about the strain on the person providing all this care?
This is a professional mandate. It's covered specifically by NICE guidance and G150 on supporting adult carers. The GMC duty says every clinician has to proactively identify carers and signpost them to support.
So it's not enough just to give them the patient update.
No, it's not. You have a duty to recognize the signs of care strain and offer them information on how they can get help.
I think this is the duty that gets overlooked the most in a rushed environment. It's hard to justify taking that time. What's the most efficient way a clinician can meet this duty without, adding 5 minutes to their consultation?
You need a quick screening question. Something like, we rely on you so much for patient B's care. Is there anything about your own health or well-being that is making this difficult right now?
Oh, that's good.
Or even simpler, have you had a formal carers assessment? If not, I can make sure you get the contact details for local support services. It's a quick way to discharge the duty, acknowledge, check for strain, offer help.
That immediately frames the whole interaction as supportive, not just transactional. Okay, let's try to pull all of these critical bits together. Let's use a memory hook, a mnemonic. How about carer?
Carer. I like it. So C would have to be.
Consent or preferences. Patient wishes guide everything.
Perfect. A is for assess capacity. If there's any doubt, you use the MCA pathway immediately.
R is for relevant minimum share. Only what's necessary for care and only securely.
Yes. E is for engage carers. Involve them, consult them, but also support them. That's the NG150 bit.
And the final R has to be record decisions.
The most important one, document who, what, why, and how you shared the information. That mnemonic is pretty robust, actually. It covers the legal accountability and the relational duty.
So let's wrap this up by looking at the trap answers, the common pitfalls that would score you very poorly because they violate all these rules.
But the easiest ways to fail, it's usually by following your gut instead of the law.
So trap number 1,
Discuss everything with relatives by default. This fails catastrophically because it just steamrolls patient autonomy and confidentiality. You cannot assume.
That's a massive boundary violation. What's next?
Second, refuse to speak to relatives at all. This is the avoidance trap. It might feel safe, but it fails if the patient wants you to involve them. You're actually obstructing safe care.
Okay, number 3.
Email full clinical notes to a family member's personal account. A double failure. It's insecure, and it's almost certainly excessive disclosure.
And the 4th, the most legally damaging one.
Skip capacity assessment and just decide on your own what you think is best. That's unlawful. It bypasses the entire mandatory best interest process.
So the red flags for you listening are basically any capacity concern, a relative asking for way too much information, or anyone using an insecure channel. If you see one of those, you have to slow down.
Exactly. Slow down and follow the structured pathway.
Okay, to summarize for you, the 3 critical takeaways from this deep dive are, first, patient wishes have to guide all information sharing decisions. It doesn't matter how helpful a relative seems.
Second, always verify identity and consent before you say anything, and then only share the minimum necessary for safe care and do it securely. Proportionality is your compass.
And third, if capacity is lacking or fluctuating, you must strictly follow the MCA best interests process. Consult and meticulously record your reasoning.
And this raises one final important question, really. Given all this complexity, fluctuating capacity, multiple relatives, time pressure, what is the single greatest defense for any action you take? It's the defensible record. The ultimate nugget here is that documenting who, what, why, and how you shared information isn't just paperwork. It is the evidence that you respected patient autonomy and that you followed the law. So the question for you is, what precise level of detail are you going to add to your notes today to make that decision truly defensible?